So now we come to our Q&A session. So do you have any questions? Okay, so I have a few questions. So to Dr. Jamal. So being a competitive neighbor, now that Singapore has routine TDM in their daily clinical practice, how do you think we can bring this technology TDM to Malaysia?
All right. Thank you, Dr. Hafiz. Yeah, I think that's very impressive to see that in Singapore, they are expanding so well with their therapeutic drug monitoring. So I think perhaps the first thing that maybe what we need to do is actually to send people. I think Singapore is the easiest one to go, very near to us, just neighbor, training, observe, and then I think of course some collaborations in pharmacokinetic studies, so that we can bring the ideas, because I think in Malaysia because we have a group of people that are quite well trained in like pharmacometrics in one of the university at the north area. We have team from the University of Malaya. I think Dr. Helmi is here. So he's very good as well in pharmacokinetics. And we have people that have a very good idea in pharmacokinetics and pharmacodynamic in the public hospital, in the Ministry of Health, but we are not integrated, So I really hope that there's an effort that we can go and at least to Singapore to see how they start, because we need a step to start with what, and then how to expand from there, what you need, how to interpret. I mean, those require some training, some experience, and then of course I think at the same time collaborating with pharmacokinetic studies will give us a much better view and understanding actually. Participating in interpreting the data analysis, all this actually can develop the skills, and of course I think it will help to expand the TDM services, not only looking at the traditional antimicrobial, the aminoglycoside, and also the glycopeptide, but also to the other important antimicrobial, and use this TDM to guide the therapy, not only to monitor in terms of minimizing the toxicity effects.
Okay, thanks, Dr. Ain. So the next question I think should go to Dr. Kwa. So there are two recent RCTs, the Target trial and Dolphin trial. So have recently been published. So the results are, so in these two studies, they compared TDM versus standard therapy. And the results did not favor TDM. And there's a recent updated meta-analysis just published in CID. So the results are also did not favor TDM. So what's your take on this? And do you think that they need to do, you need to do an RCT of comparing TDM versus non-TDM in Southeast Asian countries, where you have sicker patients, pathogens with higher MIC. So what's your take on that?
Actually, it will be understandable if in those countries where they have such findings, where the TDM doesn't have much benefit. I guess, my gut feel is they have to look at their antibiogram first for their nations, whether they have high rates of resistance or not. If they don't have high rates of resistance, then naturally you don't really need TDM, because the current dosing just still justifies, So for us to know, we know we have a certain level of resistance is not low, compared to the Western world and compared to Australia. In fact, some of our resistance rate is almost on par with southern part of Europe or even some parts of Africa. Now, the questions we are grappling with ourselves is, do every patient needs TDM? Our answers is also no. So hence we did that feasibility field around study for BLAST1. And we found that from that findings, we know that you need TDM for the list of patients with that kind of characteristics, critically ill, MDROs, high fluctuations in their fluid dynamics, hemodynamics, and with various modes of dialysis. So it's common for our patients to have CRT, HDF with auxiliary filter plus ECMO. So those patients, you will need TDM. So which is why now for our RCTs that we are zooming down into this group of patients. We are not interested in recruiting patients in a general ward, not at all. So that is where your return on investment is the biggest. And you also do not want to increase the healthcare costs by allowing everybody to be freely accessible to TDM. Now, when you have this service, if you allow this service to be rolled out to almost everybody, all right, that service may not be able to prove its worth. You see? So, and TDM service is not going to be cheap. All right, because assays development, the assays itself, the running of assays and interpretation, because you can see that each TDM, all right, it's not just merely interpreting PK/PD. You also need to look back into that patient's PK parameters. You have to dovetail back to what that patient is having at that point in time. All right, and then you work out what is the infection, how will you manage to get the right dose, right levels into that sick organ? Hence, that PK/PD target will change according to the site of infections. So it has to be very individualized. Yeah.
Yeah, thank you, Dr. Kwa. I agree. And maybe just one quick question. What's the turnaround time for beta-lactam TDM at your center? And how do you convince clinicians to perform TDM?
Actually, there's not much need to convince. When I finish my BLAST1, they ask me, I need to know the results, real time. I don't want you to tell me 1 week later. So it's not difficult to justify, to have them to come chasing us. And in fact, we do have quite a bit of resistance and fluctuations. So it's not difficult at all. It's basically the clinicians chase us to do it, period. The turnaround for beta-lactam TDM is, so once we run through our machine, is actually every 2 minutes. But you see, the timing is not with the machine. It's how fast the blood reaches us.
Okay, so thank you, Dr. Kwa. So we have come to the end of our session today, and I would like to take this opportunity to thank everyone who has contributed to making this event a success. So just a quick survey, tell us what you think. We appreciate your feedback about the session, about how can we improve, and what other topics you would like to be presented later. Just to, so we are going to have the third annual Worldwide Precision Dosing Hybrid Seminar. So there are going to be 2 sessions, one in the morning and one in the evening, just to accommodate the 2 regions, 2 different continents. So for those who have not registered, please do so as soon as possible. The next seminar is on microsampling seminar. It's going to be held on 11th of May, 2023. It's the same. For those who have not registered, please register soon. So I would like to invite everyone to visit our CRE RESPOND website. So you can see on our website the 2023 education programs that we have planned And you can subscribe to receive invitation or any updates on our program or education programs. And these sessions are all recorded, so you can just head to our YouTube channel and find the videos to these presentations. So it's free. And you can also follow us on Twitter at CRE Respond, and you can also follow us on LinkedIn. So I think we have had a valuable and informative discussion today. And I'm confident that the insights and knowledge shared by our three experts will go a long way in promoting the appropriate use of antimicrobial, not only in Asia Pacific, but globally. And again, I would like to express my gratitude to our speakers for their excellent presentations, to our sponsors for their generous support, and to our audience for their participation and engagement. So I hope to see you again soon. Thank you very much, and good night.